Angular defects are classified on the basis of number of osseous walls that were destroyed by periodontal disease, number of walls left surrounding the tooth, the number of osseous walls that will remain after surgery, or the periodontal probe readings. The number of osseous walls left surrounding the tooth. Horizontal bone loss is the most common pattern of bone loss in periodontal disease. The bone is reduced in height, but the bone margin remains approximately perpendicular to the tooth surface. The interdental septa and the facial and lingual plates are affected, but not necessarily to an equal degree around the same tooth. Vertical and angular defects are those that occur in an oblique direction, leaving a hollowed out through in the hole alongside the root. The base of the defect is located apical to the surrounding bone. Again, vertical or angular defects are those that occur in an oblique direction, leaving a hollowed out through in the bone alongside the root. The base of the defect is located apical to the surrounding bone. In most instances, angular defects have accompanying intravony periodontal pockets. Intravony pockets, however, always have an underlying angular defect. Angular defects are classified on the basis of the number of osseous walls. Angular defects may have 1, 2, or 3 walls. The number of walls in the apical portion of the defect may be greater than in its occlusal portion, in which case the term combined osseous defect is used. Important: surgical exposure is the only sure way to determine the presence and configuration of vertical osseous defects. Osseous craters are concavities in the crest of the interdental bone confined within the facial and lingual walls. Craters have been found to make up about 1/3 of all defects and about 2/3 of all mandibular defects. They are more common in posterior segments than in anterior segments. They are best treated with osseous surgery and recontouring. The relative degree of success of periodontal bone grafting is reported to vary directly with the number of bony walls on the defect, vascularized osseous surface area, and inversely with the surface area of the root against which the graft is implanted. Thus, a narrow, 3-walled angular defect usually yields the greatest success, a 2-wall defect the best success, the next best, and a 1-wall defect the least. A dehiscence is a loss of the buccal or lingual bone overlaying the root portion of the tooth, leaving the area covered by soft tissue only. The 3-wall vertical defect was originally called an intravony defect. The term intravony was later expanded to designate all vertical defects. The 1-wall vertical defect is also called hemiseptum. Suprabony pockets are associated with horizontal bone loss. they are not intraosseous. Next. When evaluating an osseous defect, the only way to determine the number of walls left surrounding the tooth is by periodontal probing, radiographs, exploratory surgery, or testing the mobility. And I will say exploratory surgery. This is because a dense buccal and or lingual plate or bone will tend to make the defect, to mask the defect, blocking it out on the radiographs. This information can only be determined by exploratory surgery. Important, radiographs will not show the number of walls left surrounding the tooth, will not show the exact configuration of the defect, and will not show the location of the epithelial attachment. Remember, the two most critical parameters for the prognosis of a periodontally involved tooth are mobility and attachment loss, which is the most crucial, the attachment loss. Angular defects are classified on the basis of the number of osseous walls. Angular defects may have 1, 2, or 3 walls. The number of walls in the apical portion of the defect may be greater than that in its occlusal portion, in which case the term combined osseous defect is used. Pocket depth is the distance between the base of the pocket and the gingival margin. The level of attachment, on the other hand, is the distance between the base of the pocket and a fixed point on the crown, such as a cemento-enamel junction. Changes in the level of attachment can be caused only by gain or loss of attachment and thus provide a better indication of the degree of periodontal destruction. Pocket formation causes loss of attachment of the gingiva and denudation of the root surface. The severity of the attachment loss is generally, but not always, correlated with the depth of the pocket. Again, severity of the attachment loss is generally, but not always, correlated with the depth of the pocket. This is because the degree of attachment loss depends on the location of the base of the pocket on the root surface, whereas the pocket depth is the distance between the base of the pocket and the crest of the gingival margin. Pockets of the same depth may be associated with different degrees of attachment loss, and pockets of different depths may be associated with the same amount of attachment loss. Which type of pocket is formed by gingival enlargement without destruction of the underlying periodontal tissues? Gingival pocket, periodontal pocket, superbony pocket, intrabony pocket. Which type of pocket? Again, which type of pocket is formed by gingival enlargement without destruction of the underlying periodontal tissues? That would be a gingival pocket, because if a periodontal pocket would be the answer, then it would not mention the absent destruction of the underlying periodontal tissue. So yes, that's a gingival pocket. Deepening of the gingival sulcus may occur by coronal movement of the gingival margin, apical displacement of the gingival attachment, or a combination of the two processes. Again, deepening of the gingival sulcus may occur by coronal movement of the gingival margin, apical displacement of the gingival attachment, or combination of the two processes. Pockets can be classified as follows. Gingival pocket, which is a pseudo pocket. This type of pocket is formed by gingival enlargement without destruction of the underlying periodontal tissues. All gingival pockets are suprabony. The base of the pocket is coronal to the crest of the alveolar bone. The sulcus is deepened because of the increased bulk of the gingiva. Again, so there is an increased bulk of the size, an increased size of the gingiva. The base of the pocket is coronal to the crest of the alveolar bone, so there is no loss of attachment because it's suprabony. Now the periodontal pocket. This type of pocket occurs with destruction of the surrounding periodontal tissues. Progressive pocket deepening leads to destruction of the supporting periodontal tissues and loosening and exfoliation of the teeth. Two types of periodontal pocket exist: intrabony and suprabony. The intrabony, also known as infrabony, subcrestal, and intraalveolar. In this type of pocket, the bottom of the pocket is apical to the level of the adjacent alveolar bone. And the suprabony, which is supracrestal or supraalveolar, the bottom of the pocket is coronal to the underlying alveolar bone, like a gingival pocket, for example, the suprabony. Why? Because the bottom of the pocket is coronal to the underlying alveolar bone. Clinical signs that suggest the presence of periodontal pockets include bluish red, thickened marginal gingiva, a bluish red vertical zone from the gingival margin to the alveolar mucosa, gingival bleeding and suppuration, tooth mobility, diastema formation, and symptoms such as localized pain or pain deep in the bone. The only reliable method of locating periodontal pockets and determining their extent is carefully probing of the gingival margin along each tooth surface. The principal differences between intrabony and suprabony pockets are the relationship of the soft tissue wall of the pocket to the alveolar bone, the pattern of bone destruction, and the direction of the transeptal fibers of the periodontal ligament. Is this true or false? The principal difference between the intrabony and suprabony pockets are the relationship of the soft tissue wall of the pocket to the alveolar bone. That's true. Pattern of bone destruction. Yes, because in infrabony, the bottom of the pocket is apical to the level of the adjacent alveolar bone. Okay, I don't know. So, next phrase. I think the first one I'm gonna say is true. So it's either 1 or 3 of these answers, which is true, both. Well, anyway, let's see the second one. In intra-bony pockets, the base of the pocket is apical to the crest of the alveolar bone, and the pocket wall lies between the tooth and the bone. I think both are true. Yes, both are true. So, distinguishing features of suprabony and infrabony periodontal pockets. The suprabony pocket, the first point of the suprabony pocket, number one, the base of the pocket is coronal to the level of alveolar bone. That's why it's suprabony. It's not under the bone level. It's suprabony pocket. Second, the pattern of destruction of underlying bone is horizontal. Horizontal. Because it's suprabony. As the difference with infrabony is that the pattern of destruction will be vertical, will be an angle, so the pocket will have the kind of the form of that vertical loss of bone. So suprabony pocket has a coronal, the base of the pocket is coronal to the level of the alveolar bone. The pattern of destruction of underlying bone is horizontal. 3. Interproximally, transeptal fibers that are restored during progressive periodontal disease are arranged horizontally in the space between the base of the pocket and alveolar bone. Again, interproximal transeptal fibers that are restored during progressive periodontal disease are arranged horizontally in the space between the base of pocket and alveolar bone. So they are horizontal, kind of. Fourth point, on facial and lingual surfaces in a suprabony, the periodontal ligament fibers beneath pocket follow their normal horizontal oblique course between the tooth and bone. So if the suprabony pocket is on the mesial or distal, there is a loss of bone that is horizontal, so the transeptal fibers are arranged horizontally from the base of the pocket and the alveolar bone. They're also in a horizontal fashion. So, and on the facial and lingual surfaces, the periodontal ligament fibers are going to continue to be its normal horizontal oblique course between the tooth and the bone. Okay, now the intrabony pocket. Point number one, the base of the pocket is apical to crest of alveolar bone because the crest is higher because it's away from the pocket and because the pattern of bone destruction is vertical. So at the bottom of the pocket will be the closest to the insertion or to the level of bone. So the bone destruction is vertical. Number 3, interproximally, transeptal fibers are oblique rather than horizontal. Why? Because the bone loss is horizontal. It's vertical. It's not horizontal, it's vertical. They extend from cementum beneath the base of the pocket, along alveolar bone, and over the crest to cementum of adjacent tooth. So, and the last one, on facial and lingual surfaces, the periodontal ligament fibers On facial and lingual surfaces, periodontal ligament fibers follow angular pattern of the adjacent bone. They extend from cementum beneath the base of pocket along alveolar bone and over crest to join with outer periosteum. In intrabony pockets, what is correct? The bone loss is vertical in nature. That is not true. Because yes, this is correct. The bone loss is not horizontal in intrabony. In suprabony, it is horizontal. And in intrabony, they're vertical. The transeptal fibers are horizontal. No, this is not true because the horizontal fibers are horizontal. The transeptal fibers are horizontal in the suprabony defect, in which the bone loss is also horizontal. So the intrabony pocket will have a vertical loss. So the supracrestal fibers follow the normal bone contour. So 1 and 4. Well, no, 4 wasn't, but here is the answer. Here we can see different types of periodontal pockets. A gingival pocket. There is a deep pocket, but there is normal bone. This is an image. And you can see that the gingiva is higher than this level. So it's been growing that way. That's why it's a gingival pocket. There is no destruction of supporting periodontal tissues. You can see the periodontal tissues are healthy here. B is a suprabony pocket. The base of the pocket is coronal to the level of the underlying bone. Here is the underlying bone. The base of the pocket is up here, is above the underlying bone. C, the intrabony pocket, in which the base of the pocket is apical to the level of the adjacent bone. The bone loss is vertical. Here is the bone and there is some loss. It's already losing bone in a vertical way. You can see right here, but there's a crest right here, and the bone is all, the base of the pocket is down here. Furcation involvements have been classified as grade 1, 2, 3, and 4 according to the amount of tissue destruction. Grade 2 is an incipient bone loss, particular bone loss, cul-de-sac, total bone loss with through and through opening of the furcation, no. Similar to the above, but the gingival recession exposing the furcation to view. Partial bone loss. So, grade 2 is partial bone loss. The term furcation involvement refers to the invasion of the bifurcation and trifurcation of multi-rooted teeth by periodontal disease. The denuded furcation may be visible clinically or covered by the wall of the pocket. The extent of involvement is determined by exfoliation with a blunt probe, along with simultaneous blasts of warm air to facilitate visualization. Furcation involvements have been classified as grades 1, 2, 3, and 4 according to the amount of tissue destruction. Grade 1 is incipient bone loss. Grade 2 is a partial bone loss, which is cul-de-sac. Grade 3 is total bone loss with through-and-through opening of the furcation, and Class 4 is similar to Grade 3 but with gingival recession exposing the furcation to view. Findings that complicate furcation involvement and account for some painful symptoms include caries of the cementum and dentin, tooth resorption in the furcation, abscess formation in the furcation, and involvement of the pulp vital lateral canals in the furcation. Definitive diagnosis of furcation involvements is made by carefully clinical probing. X-rays are helpful but only as an adjunct of the clinical examination. The major principle of treatment of involved furca is to eliminate the involvement whenever possible. A variety of methods are available for treatment. Not all of them provide for elimination of the furcation. Some provide only for increased accessibility for plaque removal. Bone grafts are relatively little effective in treating furcations. However, guided tissue regeneration is used to treat grade 2 furcations with good success. Note, furcation involvement of maxillary second molars have the poorest prognosis following therapy, and this is important because it's a question for the test. Furcation involvement of the maxillary second molars have the poorest prognosis following therapy. Why? We can think of different things, but maybe because of 3 roots, difficult to clean. Also, it's all the way in the back, things like that. Important: microscopically, furcation involvements present no unique pathologic features. It is simply a phase of the rootward extension of the periodontal pocket. In the rootward extension. Drug-induced gingival enlargement consists of a pronounced hyperplasia of the connective tissue and epithelium. Yes. Drug-induced gingival enlargement may occur in mouths, while little or no plaque, and may be absent in mouths with abundant deposits. Yes. Gingival enlargement is a well-known consequence of the administration of some anticonvulsants, immunosuppressants, and calcium channel blockers. Clinical and microscopic features of the enlargements caused by different drugs are similar. The growth starts as a painless, bead-like enlargement of the interdental papilla and extends to the facial and lingual gingival margins. As the condition progresses, the marginal and papillary enlargements unite. They may develop into a massive tissue fold covering a considerable portion of the crowns and may interfere with occlusion. When uncomplicated by inflammation, the lesion is mulberry-shaped, firm, pale pink, and resilient, with a minutely lobulated surface and no tendency to bleed when they are uncomplicated by inflammation. The presence of the enlargement makes plaque control difficult, often resulting in a secondary inflammatory process that complicates the gingival overgrowth caused by the drug. Secondary inflammatory changes not only add to the size of the lesion caused by the drug, but also produce a red or bluish-red discoloration, obliterate the lobulated surface demarcations, and increase bleeding tendency. Anticonvulsants. The first drug-induced gingival enlargements reported were those produced by dilantin, phenytoin. So phenytoin are the first drug-induced gingival enlargements reported. Other hydantoins known to induce gingival enlargement are ethotoin, which is piganon, and mephenytoin, which is mesantoin. Other anticonvulsants that have the same side effect are the succinimides, which are ethosuximide, zarontin, and metsuximide, silontin, and valproic acid, dipakine. Immunosuppressants. Cyclosporin is a potent immunosuppressive agent used to treat organ transplant rejection and to treat several diseases of an immune origin. Cyclosporin-induced gingival enlargement is more vascularized than phenytoin enlargement. Another immunosuppressive drug, the tacrolimus, has been used effectively and result in much less gingival overgrowth. So, tacrolimus have been used effectively and results in much less gingival overgrowth. Cyclosporin causes a gingival enlargement that is more vascularized than phenytoin. Okay. Calcium channel blockers. Calcium channel blockers are drugs developed for the treatment of cardiovascular conditions. These drugs are the dihydropyridine derivatives like amlodipine, which is Lotrel and Norvasc, felodipine, Plendil, nicardipine, Carden, nifedipine, Adalat, or Procardia. The benzodiazepine derivatives, diltiazem, cardizem, dilacorin, Thiazac, and the phenylacylamine derivatives, which are verapamil, Calan, Isoptil, Veral, well, whatever. Stupid names. When using the periodontal probe to measure pocket depth, the measurement is taken from the base of the pocket to the cemento-enamel junction, the free gingival margin to the cemento-enamel junction, the junctional epithelium to the margin of the free gingiva, or the base of the pocket to the mucogingival junction. Easy. Periodontal probes are used to measure the depth of pockets and to determine their configurations. The typical probe is a taper, rod-like instrument calibrated in millimeters with a blunt, rounded tip. Ideally, probes are thin and the shank is angled to allow easy insertion into the pocket. The probe is inserted along the long axis of the tooth into the pocket with a firm, gentle pressure, approximately 10 to 20 grams, until resistance is met. The probe is walked around each surface of the tooth. This method is less painful and more efficient, provides a complete and accurate assessment of the depth of the epithelial attachment, and will detect bony defects better. Periodontal probing provides the most accurate assessment of periodontal pocket depth. The true topography of vertical osseous defects cannot be determined by radiographic examination alone. Bone levels may be high, yet pockets may be deep. Excessive bone loss may exist, yet the unaccompanied, yet may be without pockets or gingiva if the gingiva has receded. The most important reason for using the periodontal probe is that it determines the loss of attachment. Notes: bleeding scores. Bleeding is still the most reliable indicator of the presence of gingival or periodontal inflammation. 2. Plaque score. With plaque disclosing solution used to help visualize plaque for the patient and clinician. Also used at multiple visits to show patients improvement of their level of oral hygiene. And 3. Recession is measured in millimeters from the cemento enamel junction to the marginal gingiva of each tooth root. So, to see it again, when you're using the periodontal probe to measure the pocket depth, the measurement will be taken from the junctional epithelium. Let's see that image that we saw earlier. From the junctional epithelium, from here to the margin of the free gingiva, junctional epithelium. We're gonna see the last one. Last card. How should a periodontal probe be adapted in an interproximal area? It should be parallel to the long axis of the tooth at the point angle. It should be parallel to the long axis of the tooth at the contact area. It should be touched. It should touch the contact area, and the tip should angle slightly beneath and beyond the contact area. It should be perpendicular to the long axis of the tooth in front of the contact area. Answer is, it should touch the contact area and the tip should angle slightly beneath and beyond the contact area. The periodontal probe may be angled approximately 10 degrees on each interproximal surface so that the tip of the probe is placed apical to the contact area of the adjacent teeth and may detect any interdental crater, but in most instances the direction of the probing is parallel to the long axis of the tooth. Periodontal measurements are taken by inserting the probe under the marginal gingiva and gently moving it down to the junctional epithelium. It feels soft, elastic, and resilient. In a healthy site, the tip of the probe stops within the junctional epithelium, and in a diseased site, it penetrates into the connective tissue. In severe disease, the probe tip may penetrate to the alveolar bone. The clinical probing depth is always greater than the histologic sulcus or pocket depth. Probing accuracy is only within +1 or -1 millimeters. Again, clinical probing depth is always greater than the histologic sulcus of pocket depth. Second note, the calibrated periodontal probe should have a taper shaft, approximately 0.5 millimeter in diameter, at the tip. It is important to have uniform instruments throughout the practice to ensure as much standardization as possible. Furcation areas can be best evaluated with the curved number 2 neighbor's probe. The periodontal probe can also be useful in the detection of the subgingival deposits. Okay, we will do one more only, just to complete 40 minutes. How should the periodontal probe be inserted into the sulcus? Oh, we just read that. Well, let's see. How should the periodontal probe be inserted into the sulcus? Perpendicular to the long axis of the tooth, with a firm push motion, with a short oblique stroke parallel to the surface of the tooth. Parallel to the tooth surface. The tip of the probe should always be kept in contact with the tooth, thus preventing soft tissue injury. The probe is gently walked along the junctional epithelium in an up and down motion called circumferential probing, always remaining under the gingival margin. It is imperative that the probe be walked along the entire gingival sulcus since the depth of the epithelial attachment varies. 6 measurements are recorded, 3 from the buccal and 3 from the lingual. Distal buccal, buccal, mesiobuccal, distal lingual, and mesiolingual. These measurements are the distance in millimeters from the base of the pocket, which is the junctional epithelium, to the margin of the free gingiva. Notes: the most important reason for using the periodontal pocket is that it determines the loss of attachment. Again, the most important reason for using the periodontal probe is that it determines the loss of attachment. These measurements are taken both before and after scaling and root planning procedures to evaluate the tissue response and the effectiveness of the treatment. Probing is performed with firm, gentle pressure. The correct probe force, approximately 10 to 20 grams. Depress the thumb pad approximately 1 millimeter to 2 millimeter. Probing is performed with firm, gentle pressure. The correct probe force depresses the thumb pad approximately 1 to 2 millimeters. That's the last one.